Hi, I'm Sharrie Harlin-Davis, and welcome to this episode of Reid Beside You. Today, we are talking about Reid Health Hospitalist, and our guests today are Cherie Frame, nurse practitioner, and Seneque Milien. Help me pronounce this again.
It's
Milien.
Seneque Milien, yes.
And he's our MD. So thanks for joining us. And before we get started, tell us how you both came to Reid, and we'll start with Cherie.
I'm actually a part of the fabric. I have been at Reid since 1992. I started out as a nurse in critical care, and I became a nurse practitioner in 2008 and joined the hospitalist group at that time.
And I've started in 2016 after I finished my residency in New York, and I've been at Reid ever since.
Yeah, great. So what is a hospitalist? And I'll let either one of you start.
Yeah, no, I'll answer that. I mean, this is, a hospitalist basically is a, let's call it an expert on inpatient medicine, whose job is basically solely to actually take care of those patients admitted to the hospital. So those can be physicians, they can be nurse practitioners, MDs or DOs, but mainly people are just basically practice medicine itself, but in the hospital setting only.
And so basically, what's their role in a patient's care?
Again, I mean, to really better understand the hospitals, you have to think of your primary care doctor. Mm-hmm. So you think about you going to your primary care doctor, and they would order all those tests for you. They'll refer you to physicians that you need to actually go to. When a patient comes to the hospital, basically that the hospitals will replace your primary care doctor. They'll do everything that your primary care doctor would have to do and more. So our role is basically to keep everyone that are needed to take care of that patient around that patient. And we actually ultimately make sure that the patients or the family members actually understand everything that's being done for that patient.
Okay. So if a patient comes to the hospital with heart failure or pneumonia or something, just on the severity of their illness, would they see a hospitalist there, or how are they referred to a hospitalist? How does that work?
A hospitalist, first of all, the hospitalist program came to be to allow the primary care providers time at home with their family instead of being there 24/7. So the providers, the physician, NP, with that collaboration with the physician, works to take care of the patient while they're in the hospital. With that being said, if they have like a heart failure issue, we might need to get the cardiologist involved, so we would consult them. If it's a kidney issue, we would get the nephrologist involved. Anything that we do inpatient, the patient's primary care provider has access to their record. They'll follow up with the primary care provider within 7 days, typically, of discharge, and the primary care provider, we will reach out to them to let them know if there's something in particular that we're not sure of. We can access their records in the outpatient setting.
Okay.
So
for our viewers, I believe traditionally, people would, if you went to the hospital, and then they would wait on their primary care doctor. So what you were saying, so that they can have a quality of life, there's your group to bridge that gap.
Not only that, is the fact that excuse me, our job is solely focused on patient care in the hospital. So I agree with Cherie. We do. It's a great thing to give those primary care doctors a chance to actually have a good family life, but you also remove them from that stress of having to actually come in from an office, run to the hospital. We in the hospital don't have to do that. We focus solely on the patient, and we would see that patient from beginning to the time they get discharged. Now, your question was, if a patient comes with CHF, pneumonia, kidney failure, if it's something medical, outside surgical, typically a hospitalist would see that patient. Now, we do have few physicians, primary care doctors who still see their own patient in the hospital. If you're not one of those, I think we have about 7 of them that still see their own patients. If you're not a patient of those 7 physicians, you likely will come to the Hospitalist Goal.
Okay. And on your team, how many people are on the hospitalist team altogether?
I think we have 8 physicians and 5 nurse practitioners at this point. We got, at any given time, we need 6 physicians to care for patients on a daily basis. That's what we call rounding. We come in at 7 a.m. to 7 p.m. and we see those patients, we take care of them, order the tests, we need to talk to family member. We typically have 1 physician that come in and admit patient for us from 12 p.m. to 12 a.m. The sole job is just to admit that patient from the ER, take care of the initial problem, and then move that patient to the inpatient setting for us to take care of when we come from on a day shift. And then we got a night team as well. Sharrie is one of the night shift NPs. So that night shift consists of 1 NP, 1 resident, and 1 physician. Their sole job is basically to cover the whole hospital, all the patients admitted. So there's always someone basically 24/7 in the hospital for all our patients at Reid that are admitted.
So that's a comforting fact for patients to know that there's always someone there.
Always.
Not so in case their primary care doctor is somewhere else, that you know you have an entire team to assist them.
Yes.
Do hospitalists have specialties?
Yes, we do. To some level, I would say. I mean, most hospitalists are either internal medicine trained or family medicine trained. The NPs and the physician assistant, it's a little bit different, but you choose where you want to actually be and that what you want to do basically, and Sharrie can speak a little bit more to that. But when it comes to the physicians, we don't specifically, hospital is not truly a subspecialty on its own yet, but it's well regarded as one already. So once you say hospitalist, most people already understand, or at least if you're in part of the medical community, you understand it's internal medicine physician or family medicine physician. So basically the same people who do primary care at the office.
Great. So Sharrie, did you have a specialty before you became under the hospitalist group?
My training is acute, so
Okay.
my focus was hospital, acute, or a specialty. However, like what Dr. Milien said, our nurse practitioners or PAs, right now we just have nurse practitioners on our team. Some have a family background and then some have acute background, but we're all trained to be inpatient hospitalists.
Right. And that's another comforting factor for patients to also see that you have all that experience and can give you the best services. When would a patient most likely encounter a hospitalist?
When a patient is admitted through the emergency room or as a direct admit from another outside facility,
Okay.
they will encounter a hospitalist. At night shift specifically, or even day shift, we have the physician and an NP. So when an NP encounters that patient, it's in collaboration with that physician, and we work together as a team. The rounding physicians take over the care after they're admitted, and we'll see their day-to-day progress and get them ready.
I just wanted to clarify that. I don't want people to say, just to walk up to the information desk and say, I really like those two. I want a hospitalist. So that's not how it works.
Let me say you do have to have the need for it. Obviously, if you I would say 98% of the reason why people are in the hospital are for medical reason. Now, when I say medical reason, because there are sometimes surgical reasons. Like I said, most of the surgical stuff will go to the surgeons, and most of the medical stuff will come to medicine people. And if you're not part of those 7 physicians who actually still see the patient, if you come to Reid, you will likely see a hospitalist.
Okay. You just don't get to choose.
No, unfortunately, you don't get to request who is gonna be your hospitalist. But we're very flexible within the group. If it's someone that we've seen before, and who would like to see us again, they can. We'll work it within the group where we can actually switch a patient for another patient.
So, in case a person was released and you had developed a very good relationship with them, do you travel with them, or it's always a referral back to their primary care physician?
It's always a referral back to the primary care physician. We do not practice outside the hospital, so we don't have an office. We can't follow a patient outside.
That's good to know.
Right.
Then also, give us some examples on how you work with the primary care physicians.
Well, let me speak to that a little bit more, because Cherie does most of the admitting, which is a little bit different from when we discharging the patient, because most of the communication that takes place between the hospitalist and the primary care doctor are within the time that you in the hospital and when you're getting ready to go home.
Okay.
So, like Cherie was saying, when you come into the hospital, we do a background check on everything that's been done for you. For example, when was the last time you saw a primary care doctor? What did you discuss with your primary care doctor? Did you see anybody else? We pull all this information in, and they help us have a good plan for you, in addition to what we're gonna be doing for your acute problem that you come in for. And on a daily basis, if we need to actually have access to your primary care doctor, we will either send them a message or we will call them. And if I have a question about a test that I need to order, I will call that primary care doctor. And the most important part of the communication is when you're ready to leave, because you want your primary care doctor to know what was done in the hospital for you and how they're gonna carry on your care. I mean, they're gonna continue to care for you outside the hospital. And we do something that's called a Discharge Summary. So we basically do a summary of everything that was done in the hospital for you, and with that we send it to your primary care doctor, and they pick up from, if there's any test that they need to follow up, we'll tell them.
So you are also private investigators almost for someone's medical history. And I know that there are people, unfortunately, that unless it's an emergency, they haven't been to see a primary care doctor. What are some of those challenges? Is that a little more challenging to find out what's going on with those patients?
It can be, especially if they're from another
area,
like outside facility or a traveler. But we do the necessary tests, and certainly their primary care provider, if it is somebody who's out of state, out of town, they can request that information.
And I'm just sharing this only because being the community outreach person, often when we're doing community screenings, often you might have someone who's 40 and they haven't had a blood pressure screening or been to the last time I was in the doctor, I was in the high school. Right. So
And we can get them.
So to get them
Yeah.
caught up and just make that transition a little smoother.
And
Right.
get them to a primary care provider.
Right.
If they're without a primary care provider, we have a resource.
Okay.
It is our policy at Reid that if you came to the hospital and you don't have a primary care doctor when you leave the hospital, you will have one. We will refer you to one to make sure at least your care is being monitored very closely.
And that'll be part of that discharge information.
Yep.
Great. The can we just highlight some more about the discharge summary? That's always a very interesting part of a hospital stay. A lot of times people have a lot of questions on, and even though everything's line item by line item, this is what you should do. Sometimes people want to do shortcuts or kind of ignore it. So,
Right. I mean, the discharge summary is actually, like you said, is complex. There are multiple parts, moving parts on it. We got the part that the physician does itself, giving you the instruction that he wants to give you. And sometimes there are multiple physicians in the case, so all those physicians will sort of like give you a little bit of information about what you need. But the hospitalist, us, would be the one that tie everything together for you and make sure that you understand. And then there's the most important person in that equation, who's gonna be your nurse. Your nurse is the one that's really gonna explain in regular term everything that you need to do. So we want every patient to actually very, pay attention to the nursing discharge instructions, because those are very important. And with that, we also have people such as our discharge planners who actually will come in and do their part. And we have schedulers that's going to schedule your tests and your appointments for you, your future appointments. So it has multiple people involved in it, but and it's complex. But at the end of the day, it's just to make sure that all the services we're supposed to have for you actually available and will get done appropriately.
another thing is because often people come to you through the emergency room. It's a time where people are uneasy. How do you talk to family members and tell us when's the best time? Because a lot of times people have to work, so maybe the caregiver or the family member isn't there. A lot of time early in the morning or they're late at night. Can you give us some tips on when's the best time they could possibly communicate with you?
Right. For a good part about being, seeing a hospital is we there 24/7.
Okay.
Now, with that being said, there's still real good time to come in and get as much information, such as the rounding team, which is like the day team. People are here from 7 o'clock in the morning to 7 p.m. They typically start seeing patients from 9 a.m. to about, I would say, 5 p.m. And the remaining hours are time that they take to actually investigate everything else that's going on. So between 9 a.m. to 5 p.m. those are perfect time to actually come in.
Okay.
Now, if you are someone who wants to come and you want to catch the doctor and it's already 6 p.m., it is okay to actually say, hey, I won't be able to make it within that time, but would I be able to actually, you can make a request at that time, but between 9 and 5, there's no request that's needed, really. You just come in and you should be able to actually ask for the doctor. They'll come back to the room and sit down and talk to you as a family member.
I'd just like that the public would know that that's a helpful point for them, because often you might talk to people and they're, well, I'm at the hospital, I'm waiting, and we're waiting on the doctor, and sometimes it's a definitely different time of the day. It's like, you're waiting on the doctor now?
Right.
So just to have a smooth transition, that they would know when's the better time.
Right. At nighttime, we still do a little bit of talking to family members as well, but you got to keep in mind that the night shift doctors are covering so many patients that they don't have they can take care of emergencies, but they don't have all the information for that specific patient. So it's a little bit more difficult when you come at night. There's always someone in the hospital, but
Right.
your information may be a little bit limited.
As well as you don't know if there's other emergencies and depending on how many people that you need to care for, that would be another challenge.
Right.
The what's the ultimate goal of the hospitalist team? And then I'm going to ask that question to both of you.
Right. Let me answer that first. You know, for us, what we've always discussed at Reid is the ultimate goal for us would be make sure that when a patient comes to the hospital, you get the best care that you can possibly get. And is one thing our founding directive always says, our program has always been a quality program where we sit there and we talk about, we don't have to see 25 patients a day. We'd rather see 15 patients a day and do a really, really good job. So we focus on that. We make it part of our goal, and that's going to continue being one of the things that we will continue to do in the future.
Cherie?
Continuity of care and it's almost like a closed loop system. You know, we work closely with the primary care providers for follow-up, and so our goal is to make it a seamless transition. And even when we, as part of the night shift admitting team, reassuring the patient and their family member that they're in excellent hands with our hospitalist physicians, and explaining our role that we are here 24/7, and your primary care provider will have all the information of your hospital stay. And
I know when Reid first put together the hospitalist program, I know we said it was about family life balance, and what were some of the other? Just a clearer transition?
Well, it opens more opportunity for patients to see their primary care providers. There's, if you've got a physician that's seeing patients in the office and coming to the hospital, they have to block out that time. So this gives more time for the primary care provider to see patients in the community.
Okay.
And this is a trend that's been going nationwide. It is just a better system in general to have that time and that person focus on just one thing as compared to multiple things. And like she said, so this is not just Reid, this is almost every hospital in the United States that will continue to have hospitalists as part of their core team to actually keep leading the healthcare systems.
And what are some of the other points you'd like to, so that we would know what happened with the hospitalists, anything I might have missed?
No, I think we covered it pretty much. I mean, the fact that I would like people to really kind of like understand what we do.
Right.
And the benefits they get from what we do, and how is it, even for themselves, the benefits that they can get themselves, and for them to understand that part of what makes this work well is having a team that's actually diligently working basically for the patients and for the patients only, really, and help Reid and the Richmond community and surrounding be healthier overall. That's pretty much our goal.
And hopefully we have a slide of the entire hospitalist team. And hopefully people understand often when they do get to the hospital, when they say, I need to see my physician, that what the benefit of working with the hospitalist. It provides them for the patient care, as well as and that you are in communication with their primary care physician.
Oh,
So-
yeah, always, always. And right, and I'm glad you mentioned that they need to understand that what we do is in collaboration with the primary care doctor, and would be pretty much done about the same way that the primary care doctor would have done it. He just allow the primary care doctor to focus on their patients and allow us to actually focus on them, the patients admitted to the hospital. It's a win-win.
So it's great. Well, I want to thank you both, Cherie
Thank you.
and Seneque, for being here. And we are and to learn all about the Reid Health Hospitalist Program. And thanks for joining us today on this episode of Reid Beside You.